90s, we used to have around 26 lakhs death because of CVD. Today, the number is around 46 lakhs. Why could that be a reason?
Genetically, Indians are prone to heart attacks.
People are losing their life probably while they're working out in a gym. Some people are running a marathon and they're coming up with issues around heart ailments. Why is this happening?
So being physically fit is important, but being physically fit doesn't mean that they do not have any cardiac problems. If there is no blood supply to the brain for more than 5 minutes, most of the brain undergoes damage. After 5 minutes, even if you do whatever you want to do, you cannot bring the person back. So learning CPR is very important for all of us.
Is there something which is more ideal to keep in vegetarian and non-vegetarian options?
If you are eating vegetarian food, doesn't necessarily have to be healthy.
What is good cholesterol or bad cholesterol? Because a lot of people villainize cholesterol.
This is about dietary cholesterol, and the blood cholesterol is definitely a villain. Chronic stress is a definite risk factor, as much as smoking, as much as diabetes when it comes to heart attack. In women, estrogen has a protective effect on the heart. So premenopausal women are at much lesser risk of developing heart attacks compared to men. But anybody above the age of 30 should have a yearly checkup of blood pressure, sugars and cholesterol.
Heart strokes happen only to elderlies and older people. Is that true?
Hi, welcome to The Other Side. I'm your host, Dilip, an entrepreneur and an endurance athlete. In this podcast, we will explore the experiences of high-performing individuals while unpacking their mental and physical fitness routines that took them to where they are.
Hi, welcome back to another new episode of the podcast. Today's episode is going to be a masterclass in heart health, a topic which has been a common interest for many people in the recent times. And for this conversation, I have a cardiologist, Dr. Deepak Krishnamurthy. Doctor has got 20 years of experience in helping patients treat various heart diseases. He's a MBBS, MD, DNB in cardiology. He's got a gold medal in DNB in cardiology and surgery. Dr. Deepak today is a senior interventional cardiologist at Kaveri Hospital in Marthahalli, Bangalore. Doctor, thank you.
Thank you.
Thank you for taking time and having this conversation with me.
Nice to be here.
There's a lot to unpack in today's conversation. Like I said in the beginning, this is going to be a masterclass for everyone who want to understand heart health from various dimensions. Like we were discussing off the record, India today is amongst the top 3 countries in the world who is suffering CVD issues, cardiovascular diseases, right? I was reading data where the deaths in CVDs across the globe, India contributes 1/5 of the global death. That's an alarming number, right? In 90s, we used to have around 26 lakhs death because of CVD. Today, the number is around 46 lakhs. I'm going to get started, of course, with the specific, but first to you. Tell me more about why did you choose cardiology and what mission are you into?
So I chose cardiology basically because it is one of the commonest diseases which affects us. It is one of the diseases which comes with the modern lifestyle, unfortunately. I have this favorite presentation of mine about lifestyle related cardiac diseases where we talk about evolution. You know, as we evolved from hunter-gatherer to agriculture to industrial to current lifestyle, physical activity became more and more uncommon, because of which the lifestyle-related diseases picked up. And diseases also evolved from starvation and infections and those deaths to now the modern lifestyle-related diseases, which are basically due to a faulty lifestyle, bad eating habits, sedentary lifestyle, lack of exercise, smoking, excessive alcohol consumption, and the several ills like excessive screen time and stuff. So, because of which most of the diseases in the current practice is related to heart diseases, related to neurovascular diseases, overall what we call as cardiovascular disease or CVD. And as you rightly pointed out, it is the top cause of death world over. In India also, because of the lack of data, we may be actually underestimating the number. I'm sure the number is 2 or 3 times the actual number stated, because there's no computerization of records. Many a times autopsy doesn't happen. Most of the time autopsy doesn't happen. So the cause of death is not clearly mentioned as a myocardial infarction or a heart attack. So our numbers are actually much more than what you presented. And India is already the diabetes capital of the world. We have a lot of diabetics, a lot of pre-diabetics, and a huge volume of insulin resistance in the society. And because of this, cardiovascular disease is more. And that is one of the reasons why I chose to be a cardiologist, because it helps me to look into more and more people with the problem and try to find a solution and try to fix it.
Yeah, so 20 years of experience, I'm sure there's a lot you have seen, the lot you have done. The idea of this conversation is to create a toolkit so that people who are listening and watching can go back and have their own operating system in what is good for them, perhaps what is not good for them, and decide how to pursue when it comes to medical intervention around staying healthy, right? So we'll try to have this conversation in 3 segments. One, which is trying to understand the basics, explain what is good heart health, right? What as a doctor do you define a good heart health?
Defining health is first very important before we define heart health. Health is of course defined as not just absence of disease, but a complete state of mental and physical well-being. Some people also add the dimension of social and spiritual well-being, but the WHO or the World Health Organization definition says it is a complete state of mental and physical well-being. So when it comes to cardiac health also, it is not just about not having a cardiac problem. Cardiac problem, the moment it comes or it is diagnosed, we are already down the slope. So cardiac health is about, of course, being free of cardiac disease and also being free of risk factors, because cardiac disease is all about risk factors. So your blood pressure has to be normal, your cholesterol has to be normal, your sugars have to be normal, you have to be physically active. To be physically active, you should have the stamina and the kind of effort tolerance to be physically active in which way you want to be, and also be free of habits which can lead to cardiac problems like smoking, tobacco use in any form, excessive alcohol consumption. So it encompasses a whole lot of lifestyle changes. It also encompasses a whole way of living differently and being in tune with your body and being able to do physical activity. A general comparison would be for a person of any age, they have to look at people of their own age group and see how much they can perform similar to others. So if a 30-year-old can compare himself to 10 other or 20 other 30-year-old people and see whether he can do the same amount of exercise, can do the same amount of physical activity within reasonable limits, that gives us a fair idea as to where we stand. So cardiac health is about a whole lot of things, about lifestyle, about habits, about physical exercise, your diet, how much of stress you are under, and how much of that stress you are able to manage without getting into too much trouble. So cardiac health is about everything.
So I have copious amount of notes today, and I realize the most common keyword is cardiac heart health. So there's either it could be confusion or there could be lack of understanding for people to understand when they're trying to simplify this definition to say that how do I assess my cardiac health or how do I assess my heart health, right? Is this two same or these two are different things?
See, if somebody is physically fit, is able to run, is able to walk, is able to exercise, people tend to extrapolate that the person is completely healthy from a cardiac point of view. May not be true. One thing which I did not include when we spoke about cardiac health is about your genetics. Sometimes we are born with faulty genes. There may be a hereditary problem with the cholesterol. There may be a hereditary problem with the blood pressure. There may be a hereditary problem in the cardiac muscle itself or in one of the ion channels of the heart. So there are a whole lot of inherited disorders of the heart which may not be apparent outside. A person may be able to run, may be able to play. You have heard about footballers collapsing on the field. Before that, they were completely fine, had a cardiac arrest, underwent a pacemaker implantation. This happened quite recently, Ericsson. So there are quite a few instances like that. So being physically fit is important, but being physically fit 100% of the time doesn't mean that they do not have any cardiac problems. there may be underlying cardiac problems which may not have produced symptoms, which may not have come to the notice and diagnosed. And at the same time, if the problems develop very slowly over time, and a person is regularly walking, exercising, may not notice symptoms initially, and it may lead to a complication or a problem at some point where it has become more severe. That also tends to happen, especially in people who start to exercise after a certain age. They already might be having certain cardiac issues, which they have not really discovered or not gone to a doctor and checked it out. Somebody starting to run at the age of 35 or 40 may already have some plaque formation in the coronary arteries of the heart, cholesterol deposits. And when they start running suddenly, that may lead to a problem. So there are various issues. It could be genetic, it could be an underlying problem which has not produced symptoms till now, or it might be rarely some event happening in a completely healthy individual. Say, human body is not something which we understand 100%. We are trying to understand, we are getting there. Over years, we have understood the diseases, the processes, the physiology, and every day we learn new. So there are areas which are probably rare, and I would say unknown complication may happen, but being physically fit, meaning being able to perform a certain physical activity like a run or exercise, may not be always the same as being cardiac-wise healthy.
That's also a very big confusion which people has got, and they can't really differentiate. I would want to build upon this as we build this conversation, but going back to your previous point, there are two type of people I would assume who come to you. One is someone who is having an existing health related ailment, or B, a second person who just walks in and says, I just want to have a checkup done. Probably might not have any signs, right? Typically assess the risk factor for both these use cases.
This is something I've always tried to address when people ask questions about cardiac health. See, coming to a doctor with a particular symptom like chest pain or breathlessness or having palpitations, having easy fatigability, not able to exercise, there my focus will be mainly on finding what is the problem and fixing that problem so that the person can get back to normal. Whereas a person who is healthy, doesn't have any symptoms, comes to me and says, I want to know my risk of developing a heart problem in future. Will I get a heart attack in future? Because say my father had a heart attack, or I have people in my family who have had bypass surgeries. So that is totally a preventive area. So people generally get confused between trying to find a diagnosis for an existing symptom versus preventive strategy. So most of the health checkup and whatever strategies we have, they are designed at the second group. That is a totally preventive strategy where we want to identify risk factors like pick up hypertension, pick up diabetes, pick up high cholesterol levels, pick up obesity, pick up other risk factors which may be there, their habits. So we arrive at a risk score based on which I can classify patients as high risk, intermediate risk, low risk. Whereas a person coming with a problem, diagnosed by means of non-invasive and invasive cardiac procedures like ECG, echocardiogram, treadmill test, an angiogram may be required at some point, or a CT angiogram, identify if blocks are there, then treat them. Then of course, along with that, we also look at risk factors, because once we find out what is the problem and treat that, we have to address the risk factors to prevent future events. So the second group of people who have never had a problem or symptom fall under primary prevention. This group who already has symptoms and some underlying problem where we need to diagnose and then look at the risk factors and address them fall under secondary prevention. So both are slightly different, because in primary prevention you do not have a problem right now, but there may be underlying risk factors depending on which you have to address their lifestyle, give medication, control the risk factors and see how it goes. In secondary prevention, you have to treat the problem first, fix it, make them fit enough to get back to normal, then look at risk factors and address them in the long term to prevent recurrent events in future. So these two are different strategies. Sometimes what happens is it gets muddled. People want to have an angiogram to know if they have a risk of heart attack. That is not how it works. Doing an angiogram or a CT will not give us the risk. It is the overall risk factors, whether you smoke or not, whether you have a family history, whether you are obese or non-obese, whether you physically exercise or not, how much stress you have, how much sleep you do. It's like driving. I tell my patients, if you do not follow rules, if you drink and drive, if you don't wear a helmet, your probability of meeting with an accident are high.
But in a very generic way today, when someone talks about heart health or heart condition, there are multiple types of heart condition, right? What are the few of the most common heart conditions do you see people these days suffering from?
So the commonest heart condition we see is coronary artery disease. Coronary artery disease meaning there are blockages in the coronary arteries or the arteries which supply the heart muscle itself. So that can lead to angina or chest pain on walking or doing physical activities, or lead to a heart attack, which is more of an acute condition. Angina is more of a stable condition where somebody may be having chest pain going on for a few months or years sometimes, whereas a heart attack is more of an acute event. So coronary artery disease includes both stable and unstable patients, and coronary artery disease is the commonest cardiac problem, followed by, of course, in India we have more valvular heart disease, where there is involvement of the valves of the heart, because rheumatic heart disease or rheumatic fever, which happens because of streptococcal sore throats in children, then leading on to heart problems, is still prevalent in India, whereas most of the developed world you do not have it.
All these different types of heart diseases would eventually lead to either a heart failure or a heart stroke. Heart failure, heart attack, heart stroke, are these interchangeably used or are these technically different?
Heart stroke is not something we commonly use. We say heart attack, that is in the common language. Technical word is of course myocardial infarction, where there is a blockage suddenly in one of the arteries of the heart, leads to damage to the heart muscle. That is a heart attack or a heart stroke. There the person has chest pain, sweating, breathlessness, has a blockage, so needs to be admitted to the hospital immediately and has to undergo an emergency angiogram, angioplasty to relieve the blockage. That is heart attack. Then you have cardiac arrest. Cardiac arrest is an electrical phenomenon where the person's heart stops. There is no pumping of blood, there is no pulse, no respiration, where you have to immediately do CPR, use shocks from outside to resuscitate the heart and bring the person out of cardiac arrest as quickly as possible, or try to do that. The third is heart failure. Heart failure is where the heart is not able to pump enough blood to meet the body requirements. That's the simplest definition of heart failure. It may be due to various reasons. It may be due to a valve problem within the heart, because one of the valves is not functioning properly. It is either blocked or narrowed, or it is regurgitating or backflowing in another direction, because the heart valves are designed basically to direct the flow of blood. Because of damage to the valve, it may either get blocked or backflow. It may be due to valve problem. It may be due to a previous heart attack because of which the heart is weak, because the heart is enlarged, not pumping properly. It may be due to one of the genetic cardiomyopathies which I previously mentioned, where the heart is enlarged and flabby, doesn't pump properly. So heart attack is where there is a blockage. It's an acute emergency. Cardiac arrest, even more severe emergency where the heart has stopped. Heart failure, where the pumping capacity of the heart is low and it is not able to meet the body requirements. Here the person usually suffers from breathlessness, not able to walk, the legs get swollen up, fluid may get collected in the lungs, and generally not able to do day-to-day activities. So that requires medication, treatment of the underlying cause, sometimes surgery, and it may lead to a cardiac transplant because the heart has completely failed. It is not able to pump unless a new heart is given from another person who has died in a road traffic accident or something. The person cannot really survive for long. So heart failure can go from very mild to very severe, where it needs a cardiac transplant, where you need a new heart. So heart attack, cardiac arrest and heart failure are three completely different things. Unfortunately, people do not understand and use it interchangeably. Even the media uses interchangeably. When somebody dies, they just casually say a heart attack or a cardiac arrest. So that is not technically right.
I hope by this people will get some clarity. Now, India has the highest number of CAD in compared to the world. Why could that be a reason?
So there are several reasons. As I told, India is the diabetes capital of the world. India is also having the largest number of people with insulin resistance. Genetically, Indians and most Southeast Asians are prone to heart attacks because of various reasons. There are several theories. Because of exposure to several droughts over years and famines over years, there has been a change in the body where the genes have adapted to store more fat in the body. So a little bit of overeating, an Indian tends to put on fat in the body, store fat in the around the organs of the abdomen, in the abdomen specifically. We have this term called the thin fat Indian. The overall person may be thin, but a little bit of abdominal obesity, a little bit of fat around the visceral organs. This leads to diabetes, heart problems, and so on. So India has the highest number of diabetes and heart problems for the same reason, because of this genetic change. Whereas if you see Caucasians, if you see other races, they need to be really obese to develop heart problems. At smaller degrees of obesity, they do not develop heart problems. Whereas Indians develop heart problems even when they are not obese. So there is a difference in our genetic way, the way our body stores fat and the way inflammation happens in the body more quickly. So as I was telling, coronary artery disease is the root cause for heart attacks, is also the cause for most of the cardiac arrests, is also the reason for most of the heart failures. But there are other causes as well, like valvular heart disease, genetic cardiomyopathies, sometimes very high blood pressure can cause heart failure, kidney diseases can cause heart failure. There are several other types of lesser common causes.
Which is the most important organ other than their heart, which depends on heart's healthy functioning? Like, I mean, you have the liver, you have the lungs, you have the kidneys. Which has the most dependency for the heart to really function well?
So all the organs, of course, in the body depend on the heart, because the heart has to pump blood to meet the oxygen requirements of the body. But the most sensitive, number one, brain, number two, the kidneys. If there is no blood supply to the brain for more than 5 minutes, most of the brain undergoes damage, because the brain has a very poor tolerance for lack of oxygen. The next is the kidney. If you have a prolonged cardiac arrest or low blood pressure, kidneys take a hit. Other organs, of course, suffer, the liver and other organs, but the brain and kidneys are the most sensitive, because they are oxygen hungry. They need more oxygen and a timely supply, and any delay causes damage to these organs. That is why in a cardiac arrest, when there is no blood supply to the brain, after 5 minutes, even if you do whatever you want to do, you cannot bring the person back, because the brain has suffered damage that leads to permanent hypoxic damage, and the person goes into coma and eventually dies. That is why the reason there is a need to encourage more and more people to learn CPR, because the moment somebody collapses, if you administer CPR and try to revive them back, the brain doesn't get damaged and they can make meaningful recovery. So brain is the most sensitive organ, followed by kidneys. So if somebody has a heart attack which is not treated on time, or if they have a cardiac arrest and low blood pressure, kidneys go into failure, may require dialysis and other support systems.
You're an interventional cardiologist. For explanation's sake for everyone, what does an interventional cardiologist do in particular? Because most of the people just know cardiologists. But can you just break down that nomenclature? How many types of cardiologists we have got?
As I told, since heart disease is so common and cardiovascular disease is the leading cause of death worldwide, cardiology is a huge branch. Cardiology is by itself a subspecialty of internal medicine. So internal medicine encompasses all departments: nephrology, neurology, cardiology, pulmonology, rheumatology, immunology. So various departments are there. So cardiology by itself is a subspecialty. Under cardiology, you have more subspecialties. You have non-invasive cardiology, basically cardiologists who do consultations, look at risk factors, do non-invasive testing like ECG, echocardiogram, treadmill tests and the like, and identify problems. Then you have interventional cardiologists who basically look at doing interventions to fix the heart problems, doing angiograms, doing angioplasties and stenting, pacemaker implantation, and now of course you do more interventions like percutaneously replacing the heart valve, what we call a TAVR, percutaneously replacing the mitral and tricuspid valves, closing holes in the heart without surgery by doing device closure. There are several interventions which you can do as an interventional cardiologist, basically fixing the heart without open surgery. So interventions are generally performed through the wrist or through the groin, where you enter a blood vessel, go backwards to the heart and fix the problem. Then there are electrophysiologists who deal with the electrical problems of the heart. They look at rhythm disturbances, do procedures to cure those rhythm disturbances. So an interventional cardiologist is like a plumber and the electrophysiologist is your electrician. So you need both to take care of the heart in an effective way. Then there are, of course, pediatric cardiologists who look at cardiac diseases in young children and newborns and treat them, diagnose them, and refer them to pediatric cardiac surgeons if surgery is required. Now, of course, you have other departments like oncocardiology, because there is a huge number of population which has cancer, and when you treat people with cancer with medication and radiotherapy and other procedures, they may develop cardiac issues, which comes under oncocardiology. So, and of course, in countries abroad, you have people who deal with genetic problems of the heart separately, cardiomyopathies and stuff. But generally, non-invasive cardiologists, interventional cardiologists, electrophysiologists, and pediatric cardiologists are the main four subspecialties in cardiology.
And what is the threshold where, as a doctor, you would want to consider interventional approach to treat the patient, and where you feel that preventive cannot hold good anymore?
Of course, initially we try to manage them with medication. If the problem doesn't appear to be very severe, many of them can be managed medically. It depends on several factors. Depends on the age of the person, how fit the person is generally, depends on what is their physical activity demands on a day-to-day basis, depends on how severe is the problem based on their non-invasive and invasive testing. For example, a young guy who's say in the armed forces, or is a pilot, or is a driver, who needs a good amount of physical fitness. In such a person, even small degrees of physical discomfort can be dangerous. So in that person, I would like to treat them invasively, fix the problem, and make them fully fit for any kind of physical activity. Whereas a more sedentary person, say a 75, 80-year-old person, not much physically active, doing day-to-day activities and have some amount of symptoms, I may try medication first, see how it goes, if the person stabilizes well, and then take up a call on doing an intervention or not. So it all depends on the whole context. So you have to look at all these parameters. The end of your analysis, you have to ask the patient as to, if I want to perform an angiogram and angioplasty, and the patient says, no, I want to try medicine for some time, I don't feel that bad, or I don't have that much symptoms, then I have to respect that and give a trial of medication first and then do the procedure. Of course, in acute emergencies, that doesn't hold.
But is that a choice for the patient?
Yes. So whether a patient wants to continue medicine, wants to undergo an angiogram and angioplasty, or wants to undergo a bypass surgery, is a decision which we have to collectively make. Sometimes the cardiologist and the patient, sometimes we involve the cardiac surgeon. So what is known as a heart team concept, where the entire team discusses the problem, what is the severity, what needs to be done, what is the best option, what is the number 2 option, number 3 option, then accordingly take a call. So what we need to understand is, it is not one parameter. We have to look at several parameters. And of course, this doesn't hold in an acute emergency. If somebody comes with a heart attack, I need to take the person for an angiogram, do an angioplasty, fix the heart, and give it the best chance to come back. Whereas in an elective scenario, where the person is more stable, we can discuss what are all the options possible, whether medication will work. Of course, if the severity of symptoms is too much, that may not be an option. But if the severity is not that much, we can try. So it all depends on a dynamic understanding of the problem, and we have to decide on a case-to-case basis. Of course, in our country, we also have the financial issues to be considered. For example, if I propose a very expensive procedure for somebody who cannot afford, that may not hold good. So I may have to try medication for some time, then see how it goes. Whereas somebody who is affordable and says, no, I want to undergo the procedure, let me be free of symptoms, please do it. So it all boils down to several factors at the end of the day. What we can do, what we need to do. Of course, there are guidelines internationally, the European Society of Cardiology, the Indian Society of Cardiology, the American Heart Association, all of them publish regular guidelines. Those serve as a benchmark as to at what level of symptoms, what level of severity we need to do this, what level of severity you need to take for surgery. There are guidelines. So we look at each disease, each parameter under those guidelines, and then discuss what are all the options possible with the patient. But of course, I wouldn't say everybody does it. There is also some amount of more aggression on some of the doctors, that they believe very firmly that no, this has to be fixed with an intervention, this has to be fixed by surgery, medicine won't work. There may be more conservative doctors who would say, no, let me treat this with medicine first and then try intervention. So there is of course variation, it is not uniform.
And in this case, what is the filter for the patient then? How do they decide, or what is their playbook, what is good or bad?
So that is where the guidelines are important. There are something called class 1 recommendation, class 2 recommendation, class 3 recommendation. Class 1, if it is mentioned in that, okay, this patient falls under class 1, you have to do it.
And this is WHO guidelines?
No, these are AHA, ACC, the American Heart Association, European Society of Cardiology.
Someone can just go up and read up that what class 1, class 2, class 3 are.
Yes.
Okay.
So if somebody falls under a class 1 recommendation to do something, say a pacemaker or an angioplasty, you have to do it. There is no doubt about it, because these are backed by huge volume of data, large number of randomized controlled trials where you unequivocally know that it will work and it has to be done. Class 2 is where you have data but not that high volume of data. So you have evidence but it is not like conclusive. Probably there you can decide whether you need to do this or that. In that again 2A, 2B recommendations are there. Class 3 is where you should not be doing it. If class 3 says, okay, this is something you should not do, somebody should not be doing that. 1 is very clear, 3 is very clear. Class 2 is where you have scope for discussion, whether you can do this or do that. Sometimes we ourselves discuss among our colleagues whether I should be doing this, whether we should continue medication. Then we reach at a consensus. Of course, discussing with the patient and family what they want to do, what is their objective and what they want to go ahead with. And of course, this is where there is also the role for second opinion. See, second opinions is something of a patient right. If patient says, no, I want to take a second opinion, generally what I do is I give them a list of doctors. These are the doctors whom you can meet and take a decision, or it is up to you. You can decide and let us know. Second opinion also happens from doctor's side. For example, if I have a doubt on something, I can always talk to my colleagues across hospitals or across cities. Now, of course, with social media, you have doctors across the globe who can give you an opinion. You can post a case detail and say, okay, what do you think I need to do? So, second opinion can happen on the doctor's side. It can also happen on the patient side. So, there are various ways to arrive at a conclusion where you have doubt, where you don't know really what to do, whether this should be done or whether we should go more aggressive. So, it all depends on various of these factors.
Yeah, no, we'll share the links of where people can just go back and refer to this, these classes. I think, like I said, our idea is to help build the knowledge base and improve, hopefully try to contribute to build the scientific temperament so that people can go back and understand all by themselves, and then of course go and seek guidance, right? A very important point which you had established earlier, which was, we didn't touch in detail, but which was very evident, is the lifestyle issue which contributes to a lot of these factors, right? For at least coronary artery disease, that's prominent. Now, it's a common knowledge. Everyone knows what a lifestyle disorder is today, right? Major factors would be your sleep, your exercise, your diet, and your stress management. Now, if I have to ask you as a specialist and a doctor who's been in this space, if you have to create a priority pyramid where what is priority and then build an order to it, what would you rank the top and how will you build that pyramid between sleep, exercise, nutrition, and stress management?
So, risk factors are something we have to look at. When it comes to, say, typhoid fever, you have one cause, which is the Salmonella bacteria. When it comes to malaria, you have one cause, which is the falciparum, Plasmodium falciparum or Vivax parasite. Whereas when it comes to heart problem, there is no one cause. You have several risk factors. All the studies which have been done worldwide, the latest data suggests that the leading cause for cardiac disease is hypertension, followed by high cholesterol levels, pollution, diabetes. Then you have other risk factors like, of course, smoking is up there. You have stress, you have genetic factors, you have sedentary lifestyle, you have sleep disturbance, deprivation, and all these things. So, we have to look at the classic risk factors, which are hypertension, diabetes, high cholesterol, smoking, along with sedentary lifestyle, lack of exercise, overeating, poor eating habits, and of course, sleep deprivation and stress. The Inter-Heart study looked at the exact pattern and risk factors. So it was conducted across 52 nations in the world, and they looked at all heart attack patients and went back in their history by 6 months to 1 year to 2 years to see what are all the risk factors. The same set of risk factors was established. The main thing which came out of it was a proper evidence that stress, which is not acute but chronic stress, is a definite risk factor as much as smoking, as much as diabetes when it comes to heart attack. So under stress, you have depression, you have anxiety, you have sleep deprivation, all these factors. So I cannot say this is one thing which I will give importance, but in a given patient you have to look at the entire list and see what all risk factors the person has. Somebody may have 2 risk factors, somebody may have 4 risk factors. So you have to give weightage to all those and then try addressing those on a individual basis.
So it's a homogeneous mix of all these factors. It could be singular, or it could be a combination of 1 or 2 together, which kind of builds into a chronic condition. Yes, right. So I want to double click on each of these factors separately. Sleep, diet, nutrition, what we talk about, exercise, and stress management. Right. So let's get into diet. In your experience, India, it's very hard to say whether you're a vegetarian country or non-vegetarian. There's a mix, but largely we are a vegetarian country, right? So between vegetarian and non-vegetarian options, now we also have plant diet option, right? Is there something which is more ideal to keep a good heart condition?
See, diet is a very controversial topic.
Yeah.
For the simple reason, what diet may be good for an American may not be a good diet for an Indian. What is good for an Indian may not be good for a Japanese guy. So we have to look at diet from a cultural background, what that particular ethnicity or race has been consuming for years, and what changes have happened in the last 50 years or 100 years because of colonization, because of urbanization, because of movement and migration of people to different countries, and of course because of corporatization and availability of different kinds of food. For example, if you look at the fast food market right now, these were not available 50 years ago. These many options to eat and overeat were not there. It was there probably in a limited place. If you wanted to have a pizza, probably you would have to go to another city to find a pizza. Because when I grew up in Mysore, I was born in 76, I was there till 2000. I don't think for the initial 20 years there was any pizza joint in Mysore. So you can see the change in food that is happening with changes in globalization. So you have to look at food at an entire cultural context. And of course, in a given patient, depending on what risk factors they have, you have to modify the diet. So we cannot say that this is one diet which will hold good for everybody. So there are cultures, there are countries who have been predominantly non-vegetarian. There are countries which have been predominantly vegetarian. In that vegetarian, non-vegetarian thing, what is not being taken into consideration is what is your mix in that vegetarian food. If you are eating vegetarian food, doesn't necessarily have to be healthy. You might be consuming a whole lot of refined flour. You might be consuming a whole lot of rice and wheat and sugar. It is still vegetarian, but you are not eating protein. You are not eating a healthy mix of fats. On the other hand, you may be a non-vegetarian, but you may be just consuming biryanis after biryanis, which has a whole lot of rice and very less of meat and chicken. You're not really a non-vegetarian. You are basically eating a lot of rice and wheat with some non-vegetarian food. So we have to look at each diet in each person very specifically as to whether that balance of carbohydrate, protein and fat is there, whether they're getting enough vitamins and minerals and other supplements, and then look at what changes can be made to make it more healthy. At the same time, you have to keep in consideration that everybody may not be able to change everything. Somebody is a rice eater, you cannot make them a wheat eater overnight. If somebody eats wheat, you cannot make them a rice eater overnight. So you have to take into context what they are comfortable with and work on a model which works best for them, and they are also compliant with it in the long term. I may be able to put a person on a very strict diet for 3 months, 6 months. But after that, it is going to break through and they're going to go back to whatever they were doing. So you have to have that little bit of flexibility in the options we give them. I cannot make a vegetarian become non-vegetarian. I cannot make a non-vegetarian become vegetarian unless there are specific issues with that diet, in which case I may tell, okay, you reduce this, you increase this. But Giving a blanket statement that being a carnivore is good, being a vegetarian is good, being a vegan is good, doesn't hold water. It has to be flexible and it has to be tailored to the particular person in his ethnic and cultural context.
Yeah, I'm glad that you brought that point because, like I said in the beginning, I mean, there's a lot of hidden agenda and an interest which people have got to drive a certain point. There's a lot of, because of industrialization, because of consumerization, right? Brands getting into a certain product line. People would say keto diet is good, or a plant-based diet is good, or a carnivore diet is good.
Yeah.
And therefore, large part of people who are at the other end trying to understand what is right or wrong doesn't have that certain toolkit, right? And they're confused. And on the other end, if plant is genuinely good, the person who is trying to canvas for carnivore would be saying that plant is bad and carnivore diet is good, right? So essentially the takeaway is that there is a risk whether you are a vegetarian or a non-vegetarian or a plant-based, right? Sticking to a one particular choice because of the cultural reason doesn't really guarantee whether you're doing everything right. It doesn't tick all the boxes, right? Double-clicking on specifically non-vegetarian, right? What's the science around red meat? Is red meat good? Does it worsen the condition? Does it aid? What's the science?
So, red meat consumption has been linked in studies to a higher incidence of coronary artery disease, to a higher incidence of certain cancers, and overall longevity being less among predominant red meat consumers. So, somebody who is non-vegetarian has to have a healthy mix of lean meat like white meat, chicken and fish, and red meat rather than going for only one kind of thing. Moderation is the key. Anything over and above a certain level will have its own consequences. For example, if you talk to a hardcore non-vegetarian, they'll say you are eating vegetables, you are eating greens. They all have pesticides. But you have to also understand that when there are pesticides in plants, there is a phenomenon called bioamplification, which happens, and the animals you eat will have a higher level of those pesticides. So this is a simple high school concept. So when plants have a certain level of toxin, that will get amplified when you go up the food chain. So there are no, I think this kind of judgmental thing should stop, and moderation is something that should happen. For example, I have patients who are vegetarians, but when you suggest you should increase your protein intake, is it okay for you to eat egg? Some of them are okay with it, some of them are not okay with it. So that is where you have to kind of bring in a conversation and consensus as to what a person can do. I can't say, okay, your diet is not good, you're a vegetarian, you just start eating non-vegetarian food. I can't do that. I mean, it goes against that person's personal choice. So we have to respect that personal choice and see what flexibility can be brought about. Somebody may be okay taking supplements derived from animal source, like omega-3 fatty acid. It is taken from fish, but people are okay to take it, but they may not be okay eating fish. So you have to bring in a consensus and discussion, and what best works and what best can be maintained in the long term is what is good. Because we have had people who have eaten vegetarian food forever and lived long lives. We have had people who have eaten non-vegetarian food and lived long lives in countries like Japan and China. If you see, their food is completely either seafood or other non-vegetarian food, and they do consume rice also. So longevity and health and disease is a function of various factors, and diet is one part of it, and we have to fit in that diet taking into consideration the choices and what can be done and cannot be done.
So India has a very eclectic mix of food choices, right? Almost 1 billion food choices we have got. And the palette which we have, agnostic to whether we are south, north, east, west, fried food is a common language, right? When we talk about fried food, very obvious thing which comes is cholesterol. So what is cholesterol in generic, as an extension to the fried food concept, and what is good cholesterol or bad cholesterol? Because a lot of people villainize cholesterol, but there's something called as good cholesterol also, right? So can you just elaborate on that?
See, when it comes to cholesterol, there are two different cholesterol basically. One is the cholesterol which is present in food. For example, egg yolk. Egg yolk has cholesterol. the cholesterol what is there in your body is not the same cholesterol. Your liver synthesizes all types of cholesterol depending on your dietary intake and secretes them into the blood. So all different kinds of cholesterol which are there in the body are produced by your own liver. So what you eat in your food, that's a different cholesterol, and that may not have a direct link to what cholesterol is there in your blood. So the cholesterol level in the blood depends on your genetic factors, because you may carry a gene which makes your liver produce cholesterol differently or more, in which case even if you don't eat any bad diet, you may have very high cholesterol.
So does everyone as a humankind carry the cholesterol in their blood, or does it come as we grow?
No, even at birth when you check for cholesterol, there is some cholesterol in the blood. It is not zero. And these have different functions in the body, carrying vitamins. Like there are fat-soluble vitamins in the body, A, D, and E and K. Without fats, you cannot absorb these vitamins, and these cannot be transported in the blood. And these cholesterol molecules are also important parts of the nervous system. They cause myelination of the nerves and the brain, and they have important functions on the cells and various organs where they act as important mediators. For example, steroid synthesis in the body requires cholesterol. Myelination of the nerves depends on cholesterol. So you have normal functions of these molecules as well. So some amount of dietary intake of fat is important in order to maintain the body functions and normal physiology. Now, which fat is good, which fat is bad is a hugely debatable topic. But as long as you keep your fat intake moderate, say 15 to 20 ml or 15 to 20 grams of fat in a day, in a mix of say ghee, butter or vegetable oils is okay. But if you exceed that on a regular basis by eating fried food or whatever it may be, it is not good for health. So it all comes to moderation and balance again. So if you are going to ask about fried food, okay, once in a way eating a pakoda or some other fried food may be okay. But if it is something you do on a daily basis, not good. You have to chart out your diet, see how much fat you are consuming, how much carbohydrates you are consuming. Among those carbohydrates, whether you are consuming too much simple carbohydrates and sugars, how much of complex carbohydrates with fiber you are consuming, protein. What is the quality of protein? So for example, if somebody is 15-year-old, 20-year-old and playing on a daily basis, burning all the calories, eating a little more oil or butter or ghee may be okay. But in a more sedentary person who already has certain health issues, has high cholesterol, diabetes or blood pressure, it may not be okay. So you'll have to tailor it according to their health status. This is in a normal healthy individual, what I told 15 to 20 ml of fat in a day, is in a normal healthy individual who fairly exercises, is not too sedentary and doesn't have existing health problems.
Is there a certain marker on how would you quantify a typical healthy male, female in terms of, I don't know, could be weight, could be heart rate, could be, what are the markers where you could just categorize that, that male or female is healthy?
So, some are basically measurements. You look at the weight, you look at the height, you come at an ideal body weight. So in simple terms, if you take the height in centimeters, subtract 100. So if you are 180 centimeters minus 100, 80 kilograms is your rough ideal body weight. Or you can take the body mass index, which can be calculated kilograms divided by height in meter square. There are other measurements like waist-hip ratio, because I spoke about abdominal obesity. So you cannot pick up abdominal obesity based on ideal body weight. Somebody may be 80 kilograms and have abdominal obesity, not much of muscular mass. There may be another person who is 80 kilograms but fully muscular, hardly any body fat and abdominal fat. So these two 80 kgs are not same. So you have to look at waist-hip ratio, you have to look at ideal body weight, you have to look at what is the body mass index, and then look at what is the fasting blood sugar, what is the cholesterol level, what is the blood pressure level. Based on these, you can come at a fair good conclusion that, okay, if this person is not overweight, doesn't have too much of waist-hip ratio, and these basic parameters are okay, 90% of the time they do not have major health issues.
Yeah. So I mean, people who are listening, watching till this moment, I mean, we'll talk more about the specific diagnostics, but highly recommend them to consider doing these blood markers on a regular intervals. What's your recommendation that how frequently should an general person who is more conscious about their health, or even if they're not conscious, they should be doing? What's the usual frequency?
Anybody above the age of 30 should have an yearly checkup of blood pressure, sugars and cholesterol. This is a bare minimum. If somebody has a family history of heart problems, more stronger hereditary factors, we may advise them to start more early and do it more frequently. But if somebody is healthy otherwise and do not have any of these problems, on a yearly basis, checking these basic parameters of body weight, sugar, blood pressure and cholesterol should identify most of the people at risk. Of course, in some people who have these risk factors, we may want to test more and look at other specific parameters. But blood pressure, sugar, cholesterol and weight, these 4 parameters can identify most of the people who are unhealthy versus healthy. Even if it is a small amount of risk, it is only going to build over time. If you are not going to change your lifestyle, if you are not going to reduce weight, if you are not going to exercise. So we can identify people, for example, somebody may have sugars always in the 70-80 range in fasting. Somebody may have the sugars always in 100-110 fasting. So if you see people who have sugars in 70s-80s range compared to those who have 110-115 range, those who have a slightly higher sugar have a higher long-term risk of developing diabetes, developing cardiovascular problems, because it is a upward slope. Where you are on the slope matters. You may not be yet diabetic. 110 is not diabetes, but compared to 80, you are already halfway up there. So your chances of becoming diabetic, your chances of developing, so blood pressure, sugar levels, cholesterol, these are all continuous variables. It is not that only at one cutoff level the risk will start. The risk slowly increases over time.
Yeah. Since you brought up sugar, how much relevance is between fasting and HbA1c? Because it could happen that your fasting is fairly okay, but your HbA1c is off the roof. So between these two, which is more relevant and which is more important?
Both are relevant, because when your fasting blood sugar is on the higher side, that means you are already closer to developing diabetes, and HbA1c reflects more of an average value over 24 hours. So both are important, and your fasting sugar also depends on how much glucose your liver is producing during the night. So both factors are important. Based on fasting blood sugar, we identify impaired fasting glucose or diabetes. But HbA1c and fasting blood sugar should both be looked at. Both have different mechanisms how they increase, and both are important in assessing somebody's risk of developing diabetes.
Previous point you said spoke about cholesterol, right? And now, like I said, there's something called a good cholesterol or a bad cholesterol, specifically LDL and HDL. Can you elaborate on those aspects?
So HDL is basically called the good cholesterol because it is involved in simply what is called as the reverse transport of cholesterol from the body. So it picks up bad cholesterol and brings it back to the liver. Whereas LDL is the other way, takes it to the blood vessels, to the coronary arteries, to the brain, everywhere, and deposits. So LDL is the bad cholesterol and HDL is the good cholesterol. If somebody has good levels of HDL above 60, above 70, it kind of negates the effect of LDL to some extent.
And this is agnostic to the age group?
Yes, irrespective of age. But traditionally, Indians have low HDL. That is one more risk factor why Indians have more risk of coronary artery disease. And the other important thing we have to look at the lipid profile is the triglyceride to HDL ratio. If your triglycerides are high and HDL is low, that means that your insulin resistance is more. And in addition to that, if you have very high LDL, it becomes even more complicated.
And why does that particular imbalance happen, that the ratios are skewed?
So when you have insulin resistance, the triglycerides are not metabolized properly in the body. So they tend to build up in the blood. So when you have a high triglyceride to HDL ratio, it is an indirect marker of insulin resistance. It could be hereditary, it could be acquired, but recently somebody was asking me on Twitter, in some article somebody said triglycerides are not to be bothered about, you just have to worry about LDL. It is not true. LDL of course is important risk factor for heart disease, but triglyceride is important because it is identifying a root cause for this heart disease, which is insulin resistance. If you have insulin resistance and if you don't address it, no matter how low you take the LDL, your risk may still be elevated because your overall metabolism is not good.
Right, let's get into the next vector, which is exercise, physical routine. Now, this is slightly controversial, but off late we have seen enough instances where people are losing their life probably while they're working out in a gym. Some people are running a marathon and just 100 meter, 20 meter away from the finish line, they crash. People who are probably doing a good amount of physical fitness per se, they're coming up with issues around heart ailments, right? Why is this happening?
So in this, there are 2-3 important points. One, of course, we have to remember that compared to say 1 million people who exercise to 1 million people who do not exercise, the mortality and the amount of cardiovascular disease and the amount of diabetes that happens in those who do not exercise is way above the population who exercises. These few deaths, these few incidents of cardiac arrest or heart attack which happen among people who exercise are outliers. They are not common events. But when it happens in a person on a treadmill or on a marathon or on the football field, it becomes more of a news. Whereas somebody who dies on their couch watching TV doesn't make it to the news. So it's a bias. So when somebody exercising dies, it becomes much more of a, it becomes headline, it becomes, the videos are circulated across the net. Everybody gets alert, oh, exercising is causing problems. It is a kind of bias. The second thing is, exercise has a J-shaped relationship with mortality. If you do not do, you have a high mortality, as I told earlier. If you exercise, that mortality comes down. But if you over-exercise beyond a certain point where you are not getting adequate rest or sleep and your body is not getting enough rest to recuperate, your mortality increases. So, again, it is about moderation, how much your body can take, how much you are trained to do a particular event. Because we see a lot of people who run marathons without any training. They just decide, okay, I'm going to run today and run 5 kilometers, 10 kilometers, and they say, okay, I finished. Lucky to be finishing, because many of them could land up with a cardiac issue or some other complication. So, training is very important for a particular event or any exercise for that matter, and to go slow and build it up gradually, depending on how you feel, what symptoms you have, whether you are able to match that performance. So exercise is 2 things. One is, there is a definite reduction in cardiovascular disease and deaths due to exercise. So if you compare people who exercise, people who do not exercise have more problems. But that doesn't make it to news. Only this, which happens among the exercising community, makes it to news. Of course, there are, as I told, outliers. They may have some underlying genetic cause, some cardiomyopathy which was not diagnosed before, some channelopathy in the heart which gave rise to a dangerous arrhythmia. Sometimes, of course, very severe exhaustion, dehydration, electrolyte imbalance during the run can cause deaths. So we have to look at this in a more, you have to zoom back and look at what is happening in the overall population. How many of people exercising are actually dying and how many of those not exercising. It is clearly a bias that you have to exercise to maintain good health, and these events which happen are outliers.
What is too much of exercise in this case? Because I'm surrounded with a lot of runners and marathoners, and the common thing, because one incident happened and it just goes viral, right? And then the obvious next few days is you should not run. Or people who are not running essentially would voice out that, look, because you're running and this happened, right? So is there a threshold where an individual can set themselves and find out their own marker that beyond this, we should not push?
See, it all depends on what is your goal of exercise. If you are somebody who wants to maintain good health, not get into trouble with diabetes and blood pressure and cholesterol and heart problems, how much exercise you have to do. Compared to somebody who wants to be more physically active on a daily basis, wants to run, wants to swim, wants to cycle as a hobby or a passion. Then you have people who are professional sportsmen whose job it is to do this. So you have to differentiate between the 3. Whether your idea is to maintain health, for which say 45 minutes of daily brisk exercise of walking or swimming or treadmill or any moderate exercise like gardening, doing routine work, climbing up stairs and up and down is enough. To be into this hobby of running or cycling or swimming or whatever it may be, or marathons, you need a more higher level of fitness, higher level of training, some understanding of physiology of running, physiology of exercise, what it takes nutritionally, in terms of what specific groups of muscles you need to exercise. For example, we used to read when Sachin Tendulkar used to play, he used to build specific groups of muscles for his pull shot. because to do that kind of a pull shot with a heavy bat with hardly any footwork, you need damn good leg muscles, lower limb muscles. So it all depends on what you want to do. Of course, if you're a professional sports person, then you have trainers, you have your doctors, you have your physiotherapists and people to advise you how to go about it. So it all depends on what you want to do. So for that particular group, this is the goal, this much should be the exercise. And during any of these endeavors, be it maintaining health or being an amateur, a marathoner or whatever, and a sports person, you need to listen to your body. Whether you're getting chest pains, whether you're getting breathlessness, whether you're able to do that kind of physical activity as comfortably as the others are doing in your group. And you have to listen to that and accept that some of these things you're not able to do. If you're not able to do, what might be the reason? Do you have any lung issues? Do you have any, cardiac issues? And then get it addressed. Sometimes what happens is, you may not be ready to accept that you have a problem. You want to just challenge and you think that by running more, you'll overcome and get into trouble. So it all depends on what is your goal of exercising and how much you want to do, how much time you can spend on a regular basis and what kind of support you have. Because some of these things do require professional help with, say, a physiotherapist or an exercise trainer, a nutritionist. Running short sprints is different, running marathon is different, doing a Ironman is different. So each one has their own specific requirements. So you need to understand the complete science and only then you can avoid trouble and maintain your track.
No, I'm super glad that you broke this down. This is only going to perhaps make people pause and rethink, because a common fallacy I see in people these days, specifically in amateurs, is that they try to pursue sports as a means to stay healthy. So they would get into running, long distance endurance, or maybe playing badminton, tennis, but then don't realize that they're crossing a threshold where they're doing it to play the sport, and that's no more tool to stay healthy. Like you said, for staying healthy, WHO says that you just need 150 to 200 minutes of cardio, right? But that doesn't mean that you do extreme endurance based activities, right? So once you get into that zone, now you are almost a athlete or a sports professional, not living a sports professional life but trying to pursue it in a very half-baked manner, and therefore it becomes extremely, because those people have to be all more mindful about their sleep, their recovery and their nutrition, which is hidden, because it just becomes an excuse for a lot of people. Because I could get my 10-kilometer run in a day, I can just go and eat anything, or I have the liberty of perhaps not going to the bed, I can go to the bed even more late. So that's a big confusion which people has got.
If you see some of these major sports stars, be it in football or basketball or cricket or any other sport, each one of them has an entire team, because they have a couple of physiotherapists, they have a couple of nutritionists, they have a doctor, they have a sports specialist, they have somebody called a sleep coach, they have some counselor, they have a sports psychiatrist, they have an entire team backing them up. So that 1 hour of performance what that person gives is backed by science and various specialists backing them up. It is not one person who is trying to Google information, read about it, ask a couple of people what to do and doing it. So we need to understand. And recently we had an unfortunate incident of a cyclist who had a heart attack and died. And we read, of course we do not know the entire information, that there was a significant lack of sleep happening because of continuous cycling and stuff. So people have to understand that the body, if it exercises a certain amount, the muscles and the heart and everything to recuperate, it takes a certain amount of sleep, a certain amount of rest. Even people who run do not run 30 days a month. They run a certain number of days, then they take rest days, they take off, they do other exercises and then get back to running. So you have to understand the science more properly. Then you will be able to maintain your health.
Yeah, I mean, I keep saying, rest and recovery are the most important part of the training days, because we ride in those endorphins. People think that rest and recovery would put them away, and that is going to, derail their fitness gains. But it's essentially going to help them gain, because your body is essentially recovering from the pieces.
When you run, when you exercise, when you lift weights, your muscles actually develop small tears. There is inflammation. And your body has to rest to get rid of that inflammation and to repair itself. If you do not give time, that inflammation is going to build up and cause problems.
Yeah. So last bit on the exercise bit, right? I mean, in the universe of exercise physiology, there are largely three forms. I'm not talking about the sport, but forms of exercise could be cardio, strength, and resistance, right? So between these three, how do you create that, again, the playbook, that what is ideal enough to stay healthy, specifically for your cardiovascular health, and when should one choose what is good for them?
So if you start exercising early enough in your life, you should be going for all three forms, which is cardio, strength, and resistance. If you are starting exercising a little later parts of your life, it is better to stick to cardio mostly and do a bit of resistance and strength. So it all depends on your age, what kind of exercise you can take, and how much are you able to maintain. Because resistance training is known to improve cardiovascular health. It reduces blood pressure. It helps various parameters of the heart. Cardio exercise is of course important to maintain, but some amount of resistance is needed. Strength training, again, it helps you in your old age. As you become older, the number of falls, then balancing issues, bone strength, a lot of these depend on how much strength training you have done and how much of muscular strength you have. So it is a healthy mix of all three, but again, depending on the age you are starting and what is your overall health status, you have to tailor it accordingly.
What is a good marker where one can understand that their exercise is aiding to a good cardiovascular fitness? So two things which I have usually read and I also try to follow is the VO2 max or your resting heart rate, right? What is your take on that?
So the resting heart rate is a good marker. So when you improve your aerobic capacity, your cardio exercises are up to mark, your heart rate tends to be on the lower level. If you have heard of good marathoners and rowing sportsmen and also tennis, there are people who have had heart rate in 35, 40s, even after playing 4 or 5 sets. So that is an extreme level of physical fitness. But yeah, if the heart rate at rest remains generally in the 90s and 100s and above, that is an indicator of lack of physical fitness. Probably some amount of background stress, increased sympathetic activity in the body, which can be brought down with regular exercise. Even to some extent, yoga, meditation, breathing exercises do help, but it is mainly about improving your overall exercise fitness. VO2 max is a good indicator. Of course, now you have Fitbits and Apple Watches and the like, with which you can monitor your heart rate, your physical activity, pair it with your smartphone, arrive at a, of course, these are derived values based on your heart rate and things. These are not direct measurements, but it will give a good rough estimate of your VO2. VO2 max, if it is in the range of 35 to 40, it is good health. If it is above 40, of course, it indicates good amount of fitness. Depending on your age, gender, there are different levels available with which you can look at your physical fitness. Of course, we have some exercise labs where they do CPET or cardiopulmonary exercise testing, where you wear a mask which measures your intake of oxygen and carbon dioxide being given out, and you can arrive at an exact VO2 also. Yeah. So heart rate and VO2 max are good indicators of your fitness, but also important is, as I told earlier, listen to your body. Whether you're feeling comfortable doing it, you're not having any undue discomfort like chest heaviness or breathlessness, feeling faint or dizzy when you're exercising, feeling extremely tired after exercising or during the exercise, and during exercise, how much is your heart rate increasing, and after resting, how quickly is it coming down. These are all important indicators. For example, if your baseline heart rate is 60 and on exercise it goes up to 140, 150, and within 1 or 2 minutes comes back to normal, it is good. But if your heart is taking, say, 5 minutes or 10 minutes to come back to normal, that indicates that there might be some issue. So heart rate baseline, how much it increases and how quickly it recovers are important parameters to look at cardiac health. VO2 max, as you told. Interestingly, we also use VO2 max for assessing cardiac rehabilitation.
Oh, okay.
When we have patients of heart failure, patients of heart attack, when we put them on rehab, we look at baseline VO2 max, how much it is improving with time. Even sometimes when we put a pacemaker for heart failure to improve the heart function.
Is there any study done where people who specifically do cardio related exercise tend to have more better VO2 than people who are doing strength or resistance?
So people who do more of aerobic exercises and cardio tend to have better VO2 max. It is known and proved in studies. And of course, graded exercise under supervision, training specific muscle groups and breathing exercises also tend to improve VO2 max, which we do in again pulmonary rehabilitation. People who have asthma, people who have bronchitis, when they undergo pulmonary rehabilitation, they are trained to use their respiratory muscles more effectively. That also improves.
What is the science which establishes the relationship between sleep and heart health?
Sleep is related to various health parameters. If you have good duration of say 7 or 8 hours on an average of sleep, which is of good quality, not only the quantity, the quality is also very important. When you wake up, you should wake up fresh. You shouldn't feel sleepy during most of the day and you should feel energetic. So the quality and quantity both matter. And when the quantity and quality are both good, your chances of developing cardiac problems are low. Your chances of developing high blood pressure are low. And even if you have high blood pressure, it will remain under better control when you sleep well. Now, there are studies linking sleep with diabetes as well. People who sleep less and do not have a good quality of sleep are also at risk of developing diabetes because insulin secretion in the body depends on the circadian rhythm, how good is the sleep. Sleep, which is basically a brain-related activity largely, is very closely intertwined with our endocrine system. Endocrine system being the pituitary, the thyroid, the pancreas, the adrenals, all the reproductive ovaries and testes. All of these are closely interlinked. When there is less sleep, the endocrine system goes haywire, all the hormonal levels are up and down. Your inflammatory activity in the body is more. There is something called neuroinflammation. So when you have sleep deprivation and low quality sleep, there is neuroinflammation, which in turn leads to cardiac inflammatory markers being high in the body because we have various mediators in the body which are pro and anti-inflammatory. When the pro-inflammatory levels go up, you have higher risk of developing blockages in the heart. If you have blockages in the heart, larger chances of developing a heart attack and adverse cardiovascular events. And purely sleep deprivation has been studied to cause cardiac arrest even in a normal heart. So if somebody goes sleepless for days together, that itself can lead to a cardiac arrest because the cardiac rhythm goes haywire. One may develop ventricular tachycardia, fibrillation and cardiac arrest. So sleep is very closely related to cardiac health, hypertension, diabetes, endocrine health and even reproductive health.
So can I then connect these dots to say that this can also be a toolkit to solve anxiety, stress? You already spoke about hypertension. So can that lead to having a certain tool around stress management?
So disturbed sleep could be due to various reasons. One could be anxiety or underlying depression. One could be due to what we call as obstructive sleep apnea. There are people who snore a lot in the night. Because of that snoring, it is not just the sound, they are not getting enough oxygen. The airways around the throat and nose are collapsing. There is low oxygen level in the blood. That leads to poor quality sleep. During the day, they feel more sleepy. The famous character Pickwickian syndrome is the name given for it, where the person tends to doze while watching TV, sitting in the bus, anywhere and everywhere in meetings. You see some people immediately doze. They might be having sleep apnea. So sleep apnea could be one reason for poor sleep quality, increased risk of hypertension, diabetes and cardiac problems. Anxiety and depression, as I told, could be reasons. The other more common and very prevalent reason is a lack of sleep hygiene. We tend to keep our mobiles next to us. Yeah. We tend to keep our laptops next to us.
More 21st century problem.
Yeah. We keep watching the TV and go to sleep. The TV is still on when you are still sleeping. So this white light exposure and this disturbance of constantly beeping phone or an email coming in or a message coming in or a call coming in. So these tend to disturb your sleep. The onset of sleep is delayed. And then even when you go to sleep, the initial few hours are not good. So this disturbs the whole cycle of sleep, which has several phases. We do not still fully understand why a person needs to sleep from a physiologic point of view, but we know that it is important. All these phases, all these things have to happen in a proper way in order to wake up fresh and energetic with with the sleep being restful. So all these factors are important. Sleep hygiene is one thing which I tell my patients that keep away your mobile phones and laptops for at least 1 hour before you go to bed. Switch off the TV, read something, and maintain a healthy, calm atmosphere in the bedroom. Don't fight with your spouse before going to bed. Simple things which you can follow where you can have a proper sleep and be healthy.
It's all, yeah, I mean, very relevant point. I mean, you have to have consistency at what time you go to the bed. That prep, like you said, before you get to the bed, what you do matters a lot in the quality and the quantity of sleep you got. And then there's enough science and evidence out there which kind of can help people build their own operating system around what their protocol should be. Since we spoke about all these three vectors, and these are, of course, not very, very novel vectors, everyone knows about it. I'm tempted to bring behavioral economics here because, or rather behavioral psychology, because although a doctor can advise a patient to say, hey, eat right, sleep well, or get some movement, it doesn't come naturally to people, specifically when we are all knowledge workers and we have calls all through the day. We are rushing up in the morning to get to our office and do our chores, right? When you see patients and you recommend them, because a large part of your work is also preventing, right? How do you try to address this when that psychology is not helping them to address those vectors and they're coming back and their markers and their metrics are not going in a favorable way? How do you then address that to the same set of people and build that understanding that how they can go back and revert? Because it's just not coming naturally to eat right, movement and sleep well.
I think if you look at a majority of people, even the patients who come to us, they all know the importance of good diet, exercise, sleep. But what is preventing them is mostly a lack of work-life balance. To maintain public health, which includes work-life balance, a reasonable number of hours of work, a reasonable amount of time for themselves. And of course, some people, despite having time, may not do it. Those people need to be reminded and counseled, and this is what you need to do. And somebody needs to show them the cost of ill health, It is not just, of course, you have to endure the ill health, the disease, the procedures, hospitalization. It also comes at an economic cost. Whatever you are earning may all be spent on a medical procedure. So at the end of the day, you have to look at health not only from a disease and prevention point, but also from an economic perspective, from a social perspective. Because once you become ill and develop certain problems, socially and economically, there are massive consequences. People having certain health issues may not be hired for certain roles. They may lose out on certain social opportunities, personal opportunities. So it has a whole lot of ramifications. It is not just about getting a heart attack, getting treatment, and coming out. It has various other aspects to it, which people...
How do you enforce this? I mean, as a doctor, your job is to fix it. How are you able to enforce factors which are outside of your control?
This is something we have to spend time on, counsel them. Of course, doctors can do a certain amount of it, but we need to have more counselors in hospitals who can talk to these people, try to understand what is their lifestyle, how it can be changed. This is where I think some amount of whatever suits them, it may be spirituality, it may be a hobby, it may be something else to which they can put their minds to as a diversion, where they can kind of understand the holistic concept of health. As I told earlier, health is not just about absence of disease. You have to be mentally and physically good, and that includes various aspects. This is something which we need to put our efforts into and spend more time, and we need people to sit with them, counsel them and make them understand. It all depends on how major the disease is also. Sometimes when you have a heart attack, people immediately come to terms with everything because they have the fear of life. When it is a more minor issue like high blood pressure or diabetes, somebody may not really understand because it's not causing that much of a life scare as yet. So it all depends on what kind of a situation they are in and how much of change they are ready to make.
Right. We spoke early in part about children and young children, even early borns having potential heart disease, right? So a lot of these lifestyle disorders are largely related to adults, right? What are the causes? I mean, can that be controlled by adults?
See, most of the heart problems we see in newborns and children are congenital heart diseases, meaning those kids are born with those defects. Either there is a hole in the heart, one of the upper or lower chambers, or one of the blood vessels is wrongly connected, or one of the blood vessels has a blockage, one of the chambers has not developed properly. There are various types of congenital abnormalities, starting from the simplest hole in the heart to very complex abnormalities in the formation of the heart itself. In this, what is important to notice, these congenital defects are more common among children of lower socioeconomic strata compared to those among the higher socioeconomic strata. This is because nutrition in a woman before and during pregnancy, habits like consuming alcohol, smoking during pregnancy, not having enough vitamins and minerals in diet, there are various factors which can lead to heart problem in the newborn. If the mother is low body weight, the children are more likely to be born with birth defects and stuff. So the nutrition of the mother, the iron deficiency in the mother, folic acid deficiency in the mother, where several nutritional aspects in the mother can adversely affect the child being born with congenital defects. Certain other factors like consensual marriages among relatives, close relatives, can sometimes make heart disease more common because certain genes get expressed more frequently. But of course, there are other disorders which are purely random, and when the child is born, immediate care can be taken and immediate identification can be done and treatment performed. That all depends on proper antenatal checkup and proper use of technology and counseling as to what can be done.
What are the basic routine tests which one should do as part of the health checkup?
So you have to do the basic physical examination, ask for a history, how is the lifestyle, smoking or non-smoking, any other use of recreational drugs, alcohol, how much, how frequently, how much of physical activity, what is the kind of diet, what is the family history like, is there any previous history of diabetes, blood pressure, high cholesterol or any of these factors. Then run basic diagnostic tests which include a lipid profile, blood sugar level, HbA1c, look at hemoglobin, look at kidney function, liver function, a thyroid test. And in selected patients, we may have to do an ECG, echocardiogram. If they complain of any physical discomfort like chest discomfort or effort intolerance, you may have to do a treadmill test to see how well they perform on exercise, if there is any abnormality in the ECG during exercise. So these are all the basic tests.
And this physical screening, sorry to double click, this is agnostic whether you are sedentary or an active person.
So if somebody runs say 10 kilometers a day, a treadmill test may not really give much information because that person is anyway going to run the treadmill. So whereas in a more sedentary person, it may give more information when we make them exercise, because some of them may not even be exercising to the point to get symptoms. So it depends on how much physically active they are. So that makes our approach also change. For example, if somebody is completely sedentary and says with minimal walking I get chest pain, that may be more severe than somebody getting chest discomfort after 10 kilometers of running or exercise. So it makes us change our approach and what we need to do. But coming to say an angiogram or a CT angiogram, these are reserved for people who have symptoms like chest discomfort or angina on walking or doing some physical work, or the non-invasive tests like ECG, echo and treadmill test have shown some abnormalities which we want to confirm as to why they are happening. So if somebody falls under a very high risk category, they have chest pain or angina and many risk factors, and the treadmill test shows that they could just walk 2 or 3 minutes with lot of changes in the ECG, I may advise an angiogram directly, admit the person, do an invasive angiogram either through the groin or through the wrist, identify what are the blockages and try to fix them either through medication or angioplasty or bypass surgery. Suppose somebody falls under a medium risk category, then I may advise a CT angiogram to look what is the problem. But if somebody falls under a low risk category, they may not need any further imaging. We just need to look at the lifestyle and risk factors and try to modify them. Of course, this is all about stable patients. If somebody comes with a heart attack, comes with more severe chest pain, we may have to jump all these and directly go for an angiogram or CT angiogram. So it all depends on, but again, At this point, I would like to make it very clear that doing an angiogram, doing a CT angiogram or even a calcium scoring is not going to give us the complete information. It is only going to say that, okay, a 40% block is there, a 90% block is there, what is there? Now, somebody having the same findings and the person is smoking, diabetic, has high blood pressure, very high cholesterols, he is going to behave differently from somebody having the same findings on an angiogram but has all these under control, is not smoking, sugars under control, blood pressure is under very good control, physically active, diet is good. So this person has every chance that they may not land in a heart attack. Whereas this person who has same findings but has all the risk factors under not good control may land up with a heart attack. So the trajectory is different for different people. So doing an angiogram alone is not going to guarantee that, okay, this fellow will not get a heart attack. It is only going to tell a snapshot of what is there right now, but his future events will depend on how well their risk factors are managed, how well their diet is managed, how well their blood pressure and other stuff is managed, and also what is the family history and what is the genetic background. So suggesting, okay, you undergo an angiogram, we'll get to know, is a wrong suggestion.
What about APOB and calcium scan? I mean, very common. Do you think that's important? How relevant they are?
Calcium scan, yes. If you do a CT of the heart and look for a calcium score, if your score is above 400, which is regarded as high risk category, that means that your plaque burden is more, meaning more arteries, more places in the arteries have cholesterol deposits, which have with time become calcific, so that calcium is showing up. So higher the plaque burden, higher will be your risk of developing heart attack in future. Suppose the calcium score is 0 or very low, your chances are lower. So that way you can modify the risk factors and treat them accordingly. So calcium score has incremental value over traditional risk stratification. I do a traditional risk stratification based on diabetes, blood pressure, smoking, stress, family history, cholesterol. I arrive at a particular score. To this score, I add calcium score. I get a slightly more specific, more sensitive score, which is more likely to reflect the overall probability of a heart problem.
So is this part of the preventive screening?
Yes.
Okay.
Preventive screening. It gives more specificity to your approach.
So it's good for general people when they're doing the preventive screening to also do a calcium scan, right?
But it should not be done frequently because it is a CT scan. At the end of the day,
Radiation.
It is going to cause some radiation. So if somebody has done a CT calcium score today, they shouldn't be repeating it for another 5 years because it won't change that fast because this calcium buildup takes time.
Good point. Yeah.
So you have to wait for some time if you want to repeat it again. But yes, it adds that additional information to my overall risk.
I see a common between runners in particular that they are advised because people specifically who are in their late 30s, 40s, they would be advised to get a TMT or ECG done. Is that also part of preventive?
See, ECG is more like a snapshot. Right now, I take an ECG. If there is any acute problem, I can make out. And some changes like related to blood pressure, other rhythm disturbances and all can be made out. But dynamic changes can be brought out only on exercise. Suppose somebody is okay at rest, ECG will be normal. But if they are getting chest pain on walking or running, if you make them do the treadmill, then you can reproduce those changes in the ECG. The other important role of treadmill test is to know the effort tolerance of the individual. If I put you on the treadmill, you can walk, you can do the treadmill say 10 minutes or 12 minutes. I get a fair idea of your effort tolerance based on which my exercise prescription and rehabilitation in case of post-event patients, or in case of somebody going for a sporting event, I can say, okay, you look fit enough, you can run. Or if somebody does a treadmill and hardly walks 3-4 minutes and has some ECG changes, I'll tell them, don't run, let's get this evaluated first and then we'll see what to do. So that's the kind of information which you can get from a treadmill test. But treadmill test has its fallacies. Unless some problem is really severe, it may not pick up.
Okay.
And it may come totally normal.
So there could be a possibility that, let's say assumingly fit person can have a favorable TMT score, but may have a, underlying health issues.
Yes. So the sensitivity and specificity of a treadmill test at the best is around 60-65%. So 30 to 35% of the time, you may be falsely positive or falsely negative meaning the report may be wrong. So you have to look at other factors, symptoms, sometimes do additional tests in order to arrive at a more better and more specific diagnosis.
What about ApoB levels?
See, the thing is, apart from the general lipid profile, that is LDL, HDL, triglyceride, total cholesterol, all the fractions, that is ApoB, ApoA levels, have not been shown in very large studies to be of value. So we don't use them routinely in risk stratification. But of course, there are studies which look at non-HDL cholesterol as a parameter, apoprotein B as a parameter, which is basically most of non-HDL cholesterol. And this has again shown a very weird kind of relationship with heart disease. There is again a J-shaped curve. At very low levels, there is risk, and then at very high levels, there is risk. In between is the zone where there is low risk. There are studies available. Of course, we generally look mainly at triglyceride HDL ratio and LDL levels. These two will give most of the information. But of course, in those having a strong family history of heart problems, we may have to look at apoprotein B levels, non-HDL cholesterol levels, look at lipoprotein small a, which is genetic in some families. If the level is high, it gives a higher risk of heart attacks. So in selected patients with more genetic background, we may do more additional testing. But for most of the people, a routine lipid profile should be good enough.
Got it. The last segment, myths, very important because there are too many, and therefore it becomes very important to debunk them, right? So I'll start with what is the myth around, and you probably can say right, wrong, and what your comment is. So first one, if you're taking drugs to lower your cholesterol level, that means you can go and eat anything. Is that right or wrong?
Statins, that is medication used to lower cholesterol, work best when they are combined with healthy diet and exercise. It holds for everything, be it diabetes, be it high blood pressure, be it cholesterol. Medication work best when you are combining it with exercise and diet. Medication alone is not sufficient. So this is a very, very unfortunate and popular myth.
Right. Second one, between men and women, men are more prone to heart attacks and heart failure. Is that right?
So because in women, estrogen has a protective effect on the heart. So younger women, premenopausal women, are at much lesser risk of developing heart attacks compared to men. But if they develop diabetes, if they smoke, or if they develop high blood pressure or cholesterol, their risk may become as much as men. The protective effect of estrogen is not there then. And of course, after menopause, they have as much risk as men as in getting heart attacks. But in the from menarche to menopause, in the reproductive age group, the risk of developing heart disease is much less because of the estrogen protecting them.
Got it. Third, if you have an heart disease, that means you can't eat anything fatty food or as little as fatty food. Is that true or not?
Again, moderation and balance is the key. It is not that we take all our heart patients off fats completely. Moderate intake of fat is okay to have.
Heart strokes happen only to elderlies and older people. Is that true?
In India, we have a bimodal peak. One peak is around the age of 30 to 40 and another peak after the age of 60. This is a very unique thing what we observe in Indians, that younger people and older people both are at higher risk. This is because of our genetic predisposition and the lifestyle changes which have happened in the last few years. We do see quite a few young people coming with heart attacks. So it is not, I would say no age is exempt from heart attack. You can have a heart attack at any age. I have seen a heart attack as young as an 18-year-old, a 19-year-old getting angioplasty and stenting. So no age is exempt, but there are two peaks, one 30 to 40 and one after age of 60.
Next is heart attack and heart stroke. They are always fatal. Is it right?
Not really.
Okay.
Heart attacks can be fatal. A significant number of them don't even reach hospital. That is true. But if they reach hospital on time and medication is started and a clot dissolving injection or an emergency angiogram and angioplasty are performed, we can save a lot of lives. It is about the golden hour concept, that you get the heart attack patient or the suspected person having a heart attack as early as possible to the nearest hospital with cardiac facilities where treatment can be performed. But yes, a significant number of them don't even reach hospital and sometimes delays, especially in places where appropriate transport is not there, rural places and all, people reach hospital very late. So fatalities, complications do tend to happen, but it is not 100%. And with time, with improvement in technologies and awareness and education, this number of fatalities is going on reducing. That is why you have more people living with heart disease, taking medication and living almost normal lives.
Got it. Between heart attack, heart stroke, we spoke about the specifics. Another myth is that it always comes with a preceding warning sign. Is that right?
In most of the patients, I would say in 50% of the patients, there may have been preceding symptoms like chest pain, discomfort, or some symptom which they have not really given importance to. But in 50% people, heart attack may be the first symptom.
Okay. So in heart strokes, it can lead to paralysis or loss of speech.
The stroke is not a heart stroke. That is basically a cerebrovascular stroke where you have a blood clot in one of the arteries of the brain, which might have gone from the heart or it might have formed in the brain. May lead to paralysis, may not lead to paralysis. Sometimes it may be just disturbed speech. Sometimes just one hand or one leg may be weak. Sometimes it may present as seizures or loss of consciousness. Depends on where and how big the clot is and how big area of the brain is involved. Many strokes, in fact, most of the strokes are silent and accumulate over time. And one of the reasons for dementia is multiple strokes happening over many years, which is called vascular dementia. So small strokes accumulate in the brain over time, and that leads to dementia because there is loss of nerve cells over time, leading to dementia. So stroke may not always have symptoms, may not always lead to paralysis.
And there no treatment when you find these incidents?
In cerebrovascular stroke, again, similar to heart attack, there is the golden hour concept. If you reach hospital within the first 2 to 3 hours, clot dissolving medication can be given in many cases.
And is exercise unsafe for people who already have an heart condition?
If the heart condition has been treated, the person has undergone an angiogram, angioplasty or a bypass surgery and is on appropriate medication, they can get back to exercise. But of course, the doctor has to decide how much of exercise the person can take and how much they should not be doing. And again, there is a huge role for cardiac rehabilitation where a graded approach is there and slowly the exercise is built up over time. And I have patients who have done angioplasties and done marathons, involved themselves in sporting activities, and the people who have had bypass surgeries who regularly exercise. So people can live a normal life, but it has to be done in consultation with their treating doctor and rehabilitation specialists.
We touched upon this very briefly, but athletes and people who look extremely fit can't have an heart attack, right or wrong?
Most of them will not, but as I said, outliers are always there. And there may be underlying problems which could be hereditary. Most of the events that happen in athletes are actually not heart attacks, but these are cardiac arrests which happen due to electrical disturbances in the heart or some underlying undiagnosed cardiomyopathy or some other reason.
What is the first mode of responder when someone sees someone going through a certain attack, guardians are around, what should they first do?
So if somebody in your neighborhood or in your office or in your, wherever you are, if you see somebody having chest pain or heaviness in the chest, sweating or having breathlessness, jaw pain or arm pain or back pain, and they're uneasy, best is to make them sit or lie down wherever they are. Do not make them walk around and do not make them drive and stuff, and call for help immediately. If you have a tablet of aspirin handy, give it to them because that's an antiplatelet drug. It starts acting immediately, and try to get the person to the hospital as soon as possible. We tell that we should have a fire escape plan, kind of a plan in every home and office and neighborhood. When somebody gets a medical emergency like a heart attack, you should have the nearest hospital number handy, ambulance number handy, doctor's number handy, so that you can quickly reach and you should know where to go. Suppose in your family you have a problem, where will you go? It should not be that at that point you think where to go, what will I do, so that you save time. And as much as possible, try to call the ambulance or somebody else can drive the person in the car rather than the person driving themselves. And if somebody has collapsed, You check the pulse, check for breathing. If it looks like a cardiac arrest, start CPR immediately, because bystander CPR, chest compressions, save a lot of lives. If you don't do anything in 5 minutes, 10 minutes, it is going to be over and you can't do anything after that. So learning CPR is very important for all of us.
Yeah. So we'll actually link probably you might have some reference for a CPR. So we'll link it in the description so that could be also a basic health hygiene what people should go through. As for a layman, how does one differentiate between a gastric pain and a heart pain? I mean, that often comes as a confusion. So how would you help them differentiate on by themselves?
Sometimes it is very difficult to differentiate because it can be very closely similar. Depends on somebody's pain threshold. If somebody has a very huge pain threshold, they may not even make out when they have a heart attack. Whereas somebody having a low pain threshold may complain as much as having a heart attack when they have gastritis. But generally, if the discomfort is central, more like a pressure, and it is going on increasing, and it is radiating to one or both arms or to the jaw, if it is associated with a lot of sweating, breathlessness, it is more likely to be a heart attack. If it is more of a burning of course can also happen in heart attack, but if it is associated with belching and burping, relieved by antacids like Digene or something you take, and it is not increasing, it subsides after some time, may not be a heart attack, maybe more, but it's always better to err on the side of caution. If you think there is something more unusual than your usual bouts of acidity, better to go to a doctor and get it checked out. Many a times it is very difficult to make out which is what, unless somebody performs an ECG and performs some additional tests.
What is a general guidance for an end patient who wants to validate whether what the doctor is telling me, whether I have to go to angioplasty or I should go to a surgery? Is it recommended that they should go and probably get a second opinion, third opinion, or if they don't have the bandwidth and it's also a costly affair, what can be their heuristic to understand what the doctor is telling is in benefit for me and there is no hidden incentives behind that?
A very tough and difficult question because it has a lot of variables. At the end of the day, it all boils down to the integrity of the doctor.
I'm sorry, just to add, I mean, not to take a lot from the doctor, but because there's a hospital administration and that's a business.
No, see, if you look at overall healthcare, most of the resources are aimed at treating diseases and very little resources going towards prevention. Because in prevention, there's not much money to be made. Maybe a few products here and there, some dietary supplements, some gyms and a few other things, or maybe smartwatches and apps may make some money. But more money is to be made in treating patients. So the hospital system, the healthcare system has generally evolved not healthcare but disease care. You're not taking care of health, you're taking care of disease, which has already happened. So for prevention to become more widespread, more systematic, there has to be a government initiative. Because when your people are more healthy, when your workforce is more healthy, the government and the organizations and even corporates have more to gain because your workforce is healthy. They are not spending more money on health and insurance and disease treatment. So there has to be an initiative from organizations, companies, corporates, factories, government to promote health. Then it can make more meaningful inroads because a simple fact, why will a hospital want prevention to happen? Because that is not their motive. Their motive is to treat diseases. Whatever disease is there, to the best of our abilities, to the best of our technological advances, we treat them. And of course, there is a fee to be paid, there is money to be made. That is normal. So for prevention to take more importance, it has to come as a larger initiative. Probably even insurance companies for that matter should look at prevention because they will be spending less money on reimbursements. The government will be spending less money on reimbursements. The corporations and companies will be spending less money. Of course, for an individual, it is more important to prevent. So on an individual level, it has to take precedence that I prevent myself from getting into a heart attack or a stroke or cancer. And from an system has to be more towards prevention. Hospitals, of course, do run preventive health checkups and everything, which people have to utilize more judiciously. And health checkup is not the end of it. health checkup has to lead to meaningful changes in diet and lifestyle and habits. Only then it will make a difference. Just going to a hospital, getting a package done is not going to change my health. What will change my health is my behavior and my changes what I'm going to make.
Yeah. So is it okay? Is it okay for people to go and take second and third opinion?
Yes. In stable conditions, when they have time, yes. But sometimes what happens is this mistrust seeps in emergency situations when it becomes very difficult for us to convince people that they have to undergo a certain procedure because there is a heart attack, there is a stroke, there is an immediate threat to life which needs to be treated. So this loss of trust, this lack of trust is actually worrying for doctors also, because when I say something to a patient in an emergency situation and they don't really trust that, it becomes difficult. Of course, in a stable situation, they can take any number of opinions and come to a conclusion what they need to do, go to a bigger center, better center, whom they trust. Of course, there has to be some kind of, which is of course now fast disappearing. There is no family doctor or such concept whom you can trust and go through them. Such system doesn't exist. You are on your own.
One thing, when I said that I'm going to talk to you, one of the most common questions which I got, and I'm assuming it's also a very controversial and speculative topic, is the impact of taking COVID vaccine to the heart conditions. So, and this is a very recent phenomena, right? Just 2-3 years old. So, has there been any research, study, any experiment done which links, or if at all there is a correlation between people who have taken COVID vaccine to any that impeding on their heart health?
In India, 2 vaccines were given. One was Covishield and the other was Covaxin. And totally around 2 billion doses have been administered in India, including the first dose, second dose, and in some people even the third dose. Like people like me have taken 3 doses. Studies which have been done to analyze risk of acute cardiac events, stroke, deep vein thrombosis or pulmonary embolism, basically all vascular events where there is a clot formation in one of the major organs. The number has been extremely low. So the number of doses administered, the number is so low, it is very difficult to have a causative link with the vaccine. Because at any given point of time in the population, there are a certain number of vascular events. Whether it is really related to the vaccine or not is difficult to say because the number is quite low. It is safe to say that most of the people who have taken the vaccine will not land up with any vascular issue or vascular event. It is safe. Only when the number becomes above a certain number, it becomes alarming. The number is not alarming. Although there are people who deny any vaccine, not just COVID. There are people who are deniers of measles vaccine. You have outbreaks of measles in parts of Europe, a disease which should practically be gone by now from earth, like polio. There are measles outbreaks because there are pockets of people who are against taking measles vaccine. There are people getting polio in outbreaks because they have not given their children polio vaccine. So there are always vaccine deniers, people who say many of the health conditions and problems are due to vaccines. Vaccine deniers are a huge group and they are very vociferous. The moment you talk about a vaccine on social media or any online platform, they attack you. But we need to understand that we have been able to remove many of these diseases from the face of the earth because of vaccines. And why we did not have a huge number of deaths after the second wave is because we were able to vaccinate a good number of people and we saved lives which could have been lost due to COVID. People say COVID is not a dangerous disease, nobody died of COVID. The vaccine killed more people, which is not true at all. There are no numbers or no data to substantiate that viewpoint. Of course, one-off event here and there has happened, and they have told in the study specifically that there is a small number of increased vascular events. I'm not talking about the RNA vaccines, mRNA vaccines which have been given abroad, the Pfizer vaccine and others. In India, the Covishield and Covaxin what have been given have been largely safe, and this myth that this has led to all these heart attacks and cardiac arrests in the recent are not true. We as cardiologists have been treating heart attacks for the last so many years, And I myself have seen young people getting heart attacks 10 years before also. Of course, the number is increasing with time over the last 20 years, but that is mainly due to change in lifestyle, overeating, lack of exercise, stress, sleep, smoking, alcohol, various factors. Even during COVID, if you take, many people were homebound, working from home, not really exercising, not really seeing their doctors for health issues like diabetes, blood pressure. There are many people whose sugars have gone through the roof during this period. And there have been various other stress factors, loss of job, loss of livelihood, lockdowns. So to blame the vaccine for everything that is happening after COVID is not correct. On the other hand, people who have had COVID, especially severe and moderate forms, during that event as well as later are found to have an increased risk of developing vascular events. So, and many of them have had vaccine also. So it is very difficult to say whether the COVID caused the problem or the vaccine caused the problem in some of these cases.
Lovely conversation we have had so far. We spoke about the past, we spoke about the present. Let's talk about the future a bit. You're in a field where there's advancement of science and technology at a very fast pace, right? How has your practice evolved from 10 years before, 20 years, the first 20 years and the second 20 years in terms of use and intervention of technology, right? Can you specify particular situations and use cases where involvement of technology has had a significant impact on how you do care and delivery of healthcare?
CT calcium score, as we were talking about, is being used more and more in the last few years. Imaging has become more specific and more widely available, which is again a technological advancement. Medication to control cholesterol. Now we have, apart from statins, we have newer medications which work at a RNA level, where the injections can be given every 6 months, to reduce very high cholesterols, which are not coming under control with statins. When it comes to treatment modalities, of course, there is a lot of change in angioplasty the way we do now. 10 years, 20 years ago, we used to do angiogram-based angioplasties, where we look at angiogram, block is there, you put a stent. Now you have imaging guidance for that. So I'm able to see inside the artery what is the status, what kind of a stent I have to put, how long should be my stent, and it has become more precise. Now we know several genes which are identified to cause cardiomyopathies, channelopathies, even risk of heart attack. But of course, we do not know how to use them in the long term. For example, if somebody comes with a genetic test and says, I have a risk, what to do, apart from routine lifestyle changes and diet, we do not really have an answer to that. Maybe in the next 25, 50 years, we will have an answer to how to make more meaningful changes based on genetic studies. Artificial intelligence is coming up in a big way. For example, now we have a CT angiogram, which we analyze with the help of a radiologist and say these are all the blocks there. Now they are coming up with an artificial intelligence algorithm which can combine the images with artificial intelligence modalities and tell which is the patient more likely to get heart attack, which is the patient less likely to get heart attack based on the composition of the cholesterol plaque.
The healthcare delivery of the country, do you have some wish list for that which perhaps people can start tinkering and try to attempt to solve for it?
So that wish list is there, but generally what happens is and entrepreneurs and people from the technical field come up with a product first and they come back to the doctor and say, how can we use this? Many a times what happens is I have no use for it. At least as on today, I may not have a use for it. But they want to somehow use that technology. But that doesn't work. People have to come up with products and solutions based on what the doctor wants. Smartwatches are good. You can monitor yourself. And again, unless you make changes in your routine, that smartwatch is not going to do anything but.
Right. No, awesome, Doc. Really appreciate you spending this much of time to help us break down the science around heart health, what happens, also your attempt to debunk that. Before we wrap it up, we both follow each other on Twitter, and I saw amongst all the other people, another common person who I follow, he doesn't follow me back, but he follows you, is our Prime Minister Narendra Modi. When did that happen?
This happened around a year and a half ago. I had posted something about recycling paper, which is something we do on a regular basis in most of middle class households from childhood. It became viral and everybody started commenting, and I had actually muted that thread. That there were so many notifications, I just muted it. Then a common friend told that Mr. Narendra Modi has commented and he has retweeted, quote-tweeted your tweet. Then I saw, and his tweet was there. He congratulated us and said this is something everybody should do. And then I went into the topic. I found that there are several tons of paper which are wasted in a city like Bangalore alone. And there is a company, I forget the name.
Okay.
They are doing this collection of paper and recycling it. And on a India level, you must imagine how much of paper can be actually recycled. And that was a topic on which Narendra Modi sir, he quote tweeted and then started following me.
As a closing note, what is that, your piece of advice for people to start taking care of their health and stay healthy?
Take care of your stress levels, sleep well, eat healthy, be moderate in your approach, be it about exercise, be it about diet. Don't take extreme views. Generally, extreme views, whether it is on social media or by any particular person, most of the time it doesn't work. So take a balanced approach and see your doctor regularly, especially if you have problems like diabetes, blood pressure. Quit smoking. Quitting smoking is one of the best things somebody can do to improve their overall health and reduce their risk of developing heart attacks. Exercise regularly and maintain a healthy work-life balance, because if there is no work-life balance, at some point you may be left with just work and no health and no quality of life.
Thank you, Doc. It was a pleasure having you and I hope to have a sit down with you very time soon, talk about more advancements in this field and probably get more feedback from people what we could not address today, but talk about. But thank you once again to take this time. So that was Dr. Deepak Krishnamurthy. We'll leave his social media handles so that you could reach. He's very generous with his time. He's pretty active on Twitter. I'm also told he's a gardening enthusiast. So if Twitter doesn't keep you excited, go to his Instagram profile. Maybe you can get some gardening tips. We'll leave his social handles on the description. You can get there, ask him any questions. He's, like I said, he answers all of them on Twitter. If this was useful to you, you could share it with your friends, family, whoever it is, to get this information out there, to help people get the right information about what is right and perhaps what is not right for their health. Thank you once again for listening and watching all this till this time. If you have any feedback for me, reach out to me, leave your comments on YouTube or Twitter, LinkedIn, any platform. If you have not subscribed to this channel, would do a great to me and my team, because we put a lot of effort in getting this content out to you. So yes, help us get this out. Go and subscribe to this channel. Thank you, and we'll get to the next episode with another new guest. Thank you. Goodbye.